Welcome, everybody. My name is Dr. Kosj Yamoah, Chair of the Department of Radiation Oncology. And this afternoon, we're just going to be talking a little bit about radiation oncology innovations and research within Moffitt Cancer Center. The mission of radiation oncology has always been to advance technology for treating cancer patients across the board through precision radiotherapy, innovative translational research, and have a global impact, because we will be the epicenter for global radiation oncology, and Moffitt is taking the lead. With our advanced precision radiotherapy, we have technologies that are able to address cancer and treat effectively based on both human anatomy and the biological constitution of everybody. We believe that every individual has a genomic fingerprint that allows us to personalize therapy for everybody. And so whether it's be a novel, new brachy suite where we're able to treat patients in one location with brachytherapy, or our MR Linac that allows us to really treat patients with real-time imaging to be able to pinpoint tumors, or it's our technologies that allows us to really shape beams right around the tumor in a crisp, precise manner that allows us to really target tumors and spare normal tissues, or our upcoming Proton Center down in the Pasco County Spurious campus coming up in 2026. All these technologies are available to make sure that we're able to precisely deliver radiotherapy to our patients, but also allow us to have innovative translational research by collaborating across the aisle with our entire Moffitt Research Institute that will do novel, innovative technologies together with our medical physicists, our physicians, our researchers to really advance the cure of cancer patients while limiting toxicities across the board. Now, looking at one specific disease size that is really something that I have a lab in, my colleague here, Dr. Conor Lynch, and myself really collaborate on. I want to walk you through prostate cancer as an example of how these collaborations pan out, from localized disease all the way through to metastatic disease. In the aspect of localized prostate cancer, we're able to use technologies like the MR Linac. We're able to use precise biopsies within our brachy suite to really interrogate the tumor microenvironment. When we move on to that advanced stage, we begin to use more advanced imaging technologies to really do combination therapies with other agents that are novel in the market to help take care of disease while still within the prostate gland. And when we go into the oligometastatic phase, which is where the disease has just got out of the prostate but it's not fully metastatic, we're able to have specialized technologies like and we call it SBRTs, which are really precise ways of giving high-dose radiotherapy to small areas that is able to really annihilate the disease right in that location and promote overall survival outcomes. Now, when the disease becomes metastatic and there seems to be very limited options, we're able to work with our researchers to come up with novel technologies. And I'm here today with my colleague to talk about a novel area of CAR-T where radiotherapy and CAR-T is really going to change the landscape of treating metastatic prostate cancer. So Dr. Lynch, take it over.
Yeah, so we work on bone metastasis. So treatments like radiation therapy, androgen deprivation therapy work really well for treating primary prostate cancer, and the outcomes are really good there. Unfortunately, we have some men that will relapse with bone metastases, and in this particular setting, we're very interested in trying to understand how these cancer cells are growing out in the bone and how they're responding to radiation, for example. And so one of the technologies that we've used that's just come online is a real game changer. It's called spatial transcriptomics. And it really allows us to take a slice of the tumor and the surrounding microenvironment and ask what each cell is doing to each other in terms of the language that they're speaking. And this has allowed us to develop different types of cellular therapies, like Kosj mentioned. One of them is a CAR-T therapy. This is a T cell that uses the patient's own T cell to engineer a receptor on it that will seek out and destroy these prostate cancer cells around the body. And it works really well, actually, for treating like liquid malignancies like leukemias, for example. And we've just opened clinical trials here at Moffitt looking at bone metastatic prostate cancer using these specialized T cells for the patients. But what we're really excited about and what we're using the spatial transcriptomic technology to understand is how precision radiation therapy that Kosj was talking about is changing the microenvironment. So you all know that radiation is going to kill the cancer cells, but it also has an effect on the surrounding cells that are working with the cancer cells to allow them to grow. And so this technology will reveal what radiation therapy is doing, not only to the cancer cells in that particular region, but also what the microenvironmental cells are doing around it. And we feel that some of the answers that we're getting with this brand new technology is really allowing us to tailor the CAR T therapy that I was just talking about to, again, enhance its efficacy and enhance its ability to kill those cancer cells in the actual prostate. And so that's what's great about research here at Moffitt. The clinicians come in with a particular problem, and we work together with the clinicians as scientists to really understand, again, some of those molecular mechanisms that are happening to come up with new drugs, be they small molecule inhibitors or cellular therapies, and then ultimately to translate them back into the clinic to help our patients here as well.
And I have to say, these innovative ideas and research projects that is destined to really change the landscape of treatments couldn't have happened without our supporters and those of you online, our patient donors. One of the projects we are describing is virtually was funded by one of our very own grateful patients that is really going to invest into that process, because this is novel. This has not been done before. These are groundbreaking areas to really see that radiotherapy is not just a one-size-fits-all.
Right.
That not only can we actually use radiotherapy to really, in a precise way, to activate interactions within the tumor microenvironment and activate T cells to help fight the cancer, but even the way you give it. We have proton therapy coming. We're going to have flash. These are high-dose radiotherapies that will go in a fraction of a second. And it turns out that these types of radiotherapy modalities actually activate the immune system quite differently than the conventional daily radiotherapy for weeks and weeks on end. And so there's new things to learn and very exciting times where we can actually begin to use radiotherapy in a very precise way, not only to just annihilate the cancer, kill the cancer cell, but really alter the tumor microenvironment to help the immune system better fight the cancer. And so this type of collaboration is really why we are very, very encouraged that you're all here really seeing what we do and understanding the process and how the sauce is made, so to speak. And also, I want to take this time to not only stay on prostate cancer, metastatic prostate cancer, where there's a exciting work going on, but really to turn the mic over to my colleague, Dr. Kamran Ahmed. He is the vice chair of our Radiation Oncology Research Program, as well as our CRMD, who is in charge of all the clinical trial portfolio within our department. And I want him to give an overview of all the different research areas that we are working through, not just prostate cancer, but everything else, and then have a few highlights, and then we can move more on to the next phase. So Dr. Ahmed, take it away.
Thank you, Dr. Yamoah, for that, and for, Dr. Lynch for that unique perspective of how we're using groundbreaking science from the lab to change what we're doing within our radiation oncology treatments. So like Dr. Yamoah mentioned, my name is Kamran Ahmed. I'm the Vice Chair for Clinical Research in the Department of Radiation Oncology, and I'm going to be sharing some of the clinical work, clinical research work that's ongoing within our department. So taking a step back, I just wanted to go over the locations at which we're treating patients and really to emphasize the point that Moffitt is a global epicenter for personalized radiation oncology. We're delivering treatments across the Tampa Bay region with our growing ambulatory care locations at the South Shore location, Wesley Chapel location, at the and at our new Spiros location that's going to be opening up very soon. And really, our goal as a radiation oncology department is to deliver personalized, dynamic, and adaptive oncology care that's really going to change the way in which patients receive radiation therapy within the state and globally as well. Next slide. And so looking at radiation therapy by the numbers, so to emphasize the point that radiation oncology is a foundational model in the receipt of oncology care. So right alongside surgical oncology, medical oncology, about 2/3 of patients ultimately after they have a cancer diagnosis may receive radiation therapy as a part of their care. Now, because of that fact, just a small incremental improvement in the receipt of radiation therapy can really have a dramatic improvement in many patients' lives. So a 5% improvement could lead to 57,000 cancer patients having improved outcomes in their oncology care, given the fact that 1.1 million patients, it's estimated, will receive radiation therapy. And this is really larger than most single disease sites or targeted therapies in terms of the dramatic effect that improvements in radiation therapy can have in oncologic care. Next slide. And so looking at our radiation oncology program specifically, so we treat patients, over 400 patients a day at 5 of our locations. We have 36 radiation oncologists that see cancer patients throughout the Tampa Bay region, a number of advanced practice professionals alongside our faculty. Equally important are our physicists who help design and make sure that our radiation therapy treatments are being delivered appropriately. And we also have a very large training and educational program as well too. We have 2 fellowship programs. We have both a medical and physics residency program. We also have a medical physics PhD program, and then we also have a radiation therapy school as well too within our department. Next slide. And our goal as a department is really to push the field forward and to have innovative translational research that is focused on patient-specific radiation therapy delivery. And really pushing the field forward in terms of precision radiation oncology is our main focus. So within this space, there's 3 main areas in which our radiation oncology clinical trials are designed. Number 1 is personalized radiation therapy, using genomics and radiomics to deliver radiation therapies that is personalized to the patient and not delivering a one-size-fits-all approach. Number 2 is novel indications for radiation therapy. And I'll be going over some of the specific examples that we have of trials that are looking at new and innovative ways of delivering radiation therapy to help cancer patients. And third would be combining radiation therapy with novel systemic agents, targeted immunotherapy agents, to see the impact that a combined approach can really have in terms of improving outcomes for cancer patients. And above all else, our clinical research mission is patient-centered to really improve outcomes for our patients. Next slide. So now I'll go over a couple of the trials that we have looking at personalized radiation therapy within our department. So number 1 is a metric that was developed by one of our faculty members within the department, Dr. Javier Torres Roca, alongside Dr. Stephen Eskridge, who's a bioinformatician at Moffitt. And that's the radiation sensitivity index. So this is a 10-gene signature, which ranks tumors between 0 to 1, with 0 being a more radio sensitive tumor and 1 being a more radio-resistant tumor. So then by analyzing a tumor on Affymetrix microarray chip, we can determine how sensitive a tumor is. And then from that score, we can determine how much radiation therapy or how little radiation therapy a tumor should receive. So this is a very unique model for radiation therapy. This is a score that's been in development over the past 2 decades at Moffitt, and now we're finally excited to be able to offer this to patients on a clinical trial basis. So this is one of the clinical trials that we have ongoing at Moffitt. This is a trial that's looking at utilizing the radiation sensitivity index score to determine the amount of radiation therapy that patients who have a triple-negative breast cancer who undergo breast conserving surgery should receive. So all of the patients on this study have a unique RSI score that's given to them. And then from that score, from that tumor score, we're able to determine how much radiation therapy a tumor should receive. So this is a study that's ongoing and really will revolutionize the way in which we treat patients following breast conserving surgery. Next slide. And now switching to another way in which we can adapt radiation therapy delivery and deliver personalized radiation oncology care. This is a study that's ongoing from Dr. Arash Nagabi, which is looking at a very unique way of treating sarcoma tumors. So sarcoma tumors are thought to be inherently radioresistant, but for many of these tumors, we can have a large impact in the way in which these tumors respond to treatment at the time of their surgery. So what Dr. Nagabi is looking is by looking at the radiomics of a tumor. So there's different pockets of the tumor that look differently on an MRI. And from there, we know which ones might be more sensitive to radiation and which might be more radioresistant. So he's basing the amount of radiation therapy that's being received by these tumors based off those pockets that are seen on the MRI, and then dosing those areas differently Another unique aspect to this study is that we'll have the tissue, so we'll have those areas that are identified to be radiosensitive and radioresistant identified at the time of their surgery, so we can really analyze the effects of our radiation therapy on the tumors from the surgical specimen. So a very unique study that's ongoing from Dr. Nagabi within our department that's really revolutionizing the way in which we treat sarcomas. Next slide. And so now we'll turn to another one of the focuses of our department in terms of clinical research, and that's combining radiation therapy with targeted and immunotherapies. Next slide. And so Moffitt has really been at the forefront in this area of research. Our investigators have had studies looking at combinations of radiation therapy with unique targeted therapies and immunotherapies across disease sites. And we've partnered with industries, and we partnered with our medical oncology colleagues to really revolutionize this space. And so we've had studies that have looked at this in the setting of breast cancer, brain metastasis, Merkel cell carcinoma, prostate cancer, and small cell lung cancer. Next slide. And one of the studies that's ongoing that's looking at this is a trial that we've opened within our department that is looking at combining radiation therapy with intrathecal trastuzumab and pertuzumab for HER2-positive leptomeningeal disease. So HER2-positive, leptomeningeal disease has been thought to be a very aggressive disease with the median overall survival that historically has been reported to be in months. This study, which has accrued 29 patients to date, is looking at utilizing radiation therapy upfront, utilizing methods such as craniospinal irradiation therapy, which has shown to have a survival benefit, or focal approaches based off of what the needs of the patient are. And then looking at delivering intrathecal therapies, trastuzumab and pertuzumab, which are HER2-directed, directly in through an Ommaya reservoir to have responses within the leptomeningeal space within the cerebrospinal fluid. So we've really seen great outcomes from this study. We just recently reported the interim analysis in terms of overall survival for our patients at the recent San Antonio Breast Cancer Symposium. And this study is, although the primary site is at Moffitt, we also have the study open at Northwestern University and at the University of Utah with our neuro-oncology colleagues. Next slide. And then touching now on the one of the final indications for really advancing our field forward within our department, looking at novel indications for radiation therapy. So this is a study that is going to be opening soon within our department. This is a work that's being led by Dr. Daniel Oliver, who's one of our neuro radiation oncologists and palliative care radiation oncologists, as well as Dr. Gage Redler, who's one of our physicists. But looking at utilizing low doses of radiation therapy to multiple sites of disease within patients. So we have good data on ablating tumors for patients who have oligometastasis or using palliative doses. But what about using low doses of radiation therapy to stimulate the immune system? There's a lot of preclinical work that has shown that this might be an approach that could be beneficial for patients. And so this is very novel work that's going to be looking at utilizing this approach to patients who have greater than 10 sites of metastatic disease, up to 50 total sites, that could really change the way in which we think about combining low doses of radiation therapy with immunotherapies to improve clinical outcomes. So this is just some of the exciting clinical research that's going on within our department. A lot of progress is being made, and it really takes the support of our generous donors and our foundation to really support the mission and the clinical research that's going on within our department. And now I'll hand it over to Dr. Jimmy Caudell, who's our section head for head and neck and endocrine radiation oncology, who will show some of the groundbreaking work that he's doing in terms of personalizing radiation therapy for head and neck cancer.
Hey, everybody. Appreciate the opportunity. My name is Jimmy Caudell. I'm the section head of head and neck and endocrine radiation oncology. And just talk a little bit about some of the things that we have going on. Next slide, please. So One of the things I did when preparing for this is I asked AI, in particular ChatGPT, what they think the major questions are in radiation oncology. And basically, it's what we're doing already, personalizing radiation therapy, integrating radiation therapy with systemic therapies, especially immunotherapy, and improving adaptive radiotherapy. And as you heard from Dr. Ahmed, we have many of these things ongoing, as well as in across the department, as well as in head and neck. Next slide. And so one of the things that we're interested in head and neck, of course, is the personalized radiotherapy dose. Next slide. And so we have great data, and Dr. Ahmed touched on this in head and neck, at least retrospectively, that using RSI and GARD allows us the potential to personalize radiation dose. So imagine coming into clinic, and instead of getting a prescription that everybody else gets, you get a prescription that is for your tumor, whether it's lower than you might expect or higher than you might expect, or exactly what we've been doing in the past. Next slide. And so, from a departmental grant and a generous donor, we've obtained funding for this trial for HPV-related oropharyngeal cancer, where we will obtain the RSI and calculate the genomically adjusted radiation dose and attempt to deliver, in addition with chemotherapy, the exact amount of radiation that patients require to cure their cancer. And so we hope to have this initiated early next year. And given the patient volumes at Moffitt Cancer Center, we anticipate this study will only take a year to accrue. Next slide. That being said, oncology care isn't perfect, and certainly patients recur. And there's a myth out there that one course of radiation is all that you can have, but there is a long history of doing radiation again, even in head and neck. Next slide. And we've been pioneers in this area. This was actually one of the first investigator-initiated trials performed in the department at Moffitt Cancer Center, where we used a new form of radiation, stereotactic body radiation, with concurrent chemotherapy for patients who had previously been radiated in the head and neck. And you can see here, this has been published with very reasonable outcomes, comparable to standard treatments, except being performed in 2 weeks rather than 6 weeks. Next slide. But we know even changing how we deliver radiation, say once a day versus twice a day, we can change outcomes. And this study in nasopharyngeal cancer showed that twice daily radiation in this setting improved survival. And interestingly, this was entirely due to reductions in toxicity. Next slide. And we see in preclinical studies that combining radiotherapy with immunotherapy, it's very dependent on how we deliver the radiation. So these preclinical studies showed that separating out the doses of radiation here, for example, by a week versus every day, improved the efficacy of radiation. Next slide. And so we proposed this study, and we're actively seeking funding for this, where we compare twice daily radiation spaced apart weekly versus stereotactic radiation spaced apart weekly, combined with chemotherapy and immunotherapy, again, to improve outcomes, reduce toxicity, and overall cure more cancers with less side effects. Next slide. So the final thing I wanted to talk about is adaptive head and neck radiotherapy. Currently, the standard for almost all radiation is we do a radiation plan based on a CT simulation that's performed prior to treatment, and you receive the same plan every day throughout the course of radiotherapy. Next slide. But people change over the course of 4 to 8 weeks of radiotherapy. Tumor shrinks, people lose weight, organs shift. And so there's a significant interest in adapting radiotherapy, and we have multiple ways to do that. As Dr. Yamoah mentioned, we have MRI Linacs, we have CT-based Linacs that can do online adaptation. But to do so it requires significant effort. And in collaboration with our physics colleagues, we're doing a large amount of research to make this process much quicker. So we've developed deep learning algorithms for contouring. So all you have to do is press a button, and in 30 seconds, you have all the organs at risk contoured. And we've shown that this is almost as good and results in the same quality of radiation plans using these deep learning based contours. And we published on using the imaging that we obtain on a daily basis during the radiation plans to calculate doses. And then in collaboration with some software partners, we're working on auto planning. And so you can imagine if we can automate this entire process, we can do new radiation plans on a daily basis, a weekly basis. We can run this through algorithms that predict, how much toxicity we're saving or how much we're overdosing or underdosing the tumor. And so we hope to have this very soon for clinical practice, which will open up new avenues of research and hopefully improve patient outcomes. Next slide. So at the end of the day, one of the reasons that we're doing this is because we need to get the word out. In Dr. Ahmed's presentation, he noted roughly 2/3 of all patients receive radiation during the course of their oncology care. However, radiation oncology is significantly underfunded. So there was a recent analysis of governmental funding, NIH, NCI, and radiation oncology represents less than 0.5% of the total NIH budget and less than 2% of the NCI budget. So for a modality that is involved in 2/3 of oncology patients, we're significantly underfunded. In addition, industry funding is very limited for radiation oncology. On the right, you see less than 6% of radiation oncology trials received industry funding. And so we've done, I think, a pretty good job in the department supporting our faculty to run interesting, innovative trials, but we certainly need more help. Next slide. So that's it. Thank you very much. Happy to take any questions.
Thank you so much, Dr. Caudell. This time I'd like to introduce our Director of Major Gifts, Tyler Wilson at the Moffitt Foundation. And then please continue to put your questions in the chat. And whilst Tyler is giving us a few remarks, and then we'll take a Q&A after that. So over to you, Tyler.
Thanks, Dr. Yamoah. And I really appreciate everybody's time this afternoon. I think the presentations today really reflect the broad impact that philanthropy has within the radiation oncology program here at Moffitt. From seeing the live look in the lab with Dr. Yamoah and Dr. Lynch, and understanding what it takes from a basic science and translational level to really advance towards all of the clinical trials that we saw presented today, and really every aspect of that being supported by philanthropy here at Moffitt within radiation oncology, I think just demonstrates the meaningful impact that all of our partners have provided, whether they're supporting specific initiatives or providing a gift that's across the board to support any of these initiatives within radiation oncology. I've been at Moffitt now for about 5 years, and really to see this exciting time that the radiation oncology department has reached and the level of personalized care that they can provide, all thanks to our generous philanthropic donors, and to see things from immunotherapy to personalized medicine, and Dr. Caudell kind of ending on the next steps and transitions with AI really gives a full scope of the research and the impact that your department is having. And so, if you'd like to make a gift to radiation oncology, it's very easy to simply designate that gift either on the memo line of the check or an accompanying letter, or sending me an email or giving me a call. You can simply note radiation oncology on your gift, and your gift will go towards impacting all of these initiatives and give Dr. Yamoah and his team the opportunity to really make an impact across so many different disease areas that they support at the institution. So my contact information is listed on the screen. I'm happy to talk or answer any questions if the time is right for you to make a gift to Moffitt. Thanks so much.
Thank you so much. Thank you so much, Tyler. This time we will be going into some question and answer time, and I'll try to moderate this session to the best of my abilities. We may not be able to get to all the questions, but we'll do our best to get to as many of them as we can. And the first question I see here is really asking the question, why is GARD so important for personalized care? And that was really a question that I think Dr. Caudell will be able to answer the best. So go for it.
Yeah, so currently in radiation oncology, in radiation treatments, we have no biomarkers to guide us about an individual patient's radiosensitivity. And we know from clinical practice that some patients respond very, very quickly and some patients don't respond at all. And so RSI and GARD is a way to potentially interrogate an individual's radiosensitivity of their tumor and transmute that into a personalized dose. And so currently in clinical practice, we're very evidence-based. We have a multitude of randomized phase 3 trials. So for example, in head and neck, all randomized phase 3 trials deliver 70 gray in 35 fractions. But for example, we ran a phase 2 trial where we gave everybody 60 gray and we cured 92% of people. But when we tested it in a phase 3, 70 gray still won because we cured 98% of people. But 92% didn't need 70 gray. There was a small fraction of people that needed 70 gray. And so we can use a biomarker to decide who needs 60, who needs 70, who needs more. Then we cure more people with less fractions of radiation. So instead of coming 7 weeks, you come 6 weeks, you get less dose, you get less side effects, and it's a huge win. But we have to prove it, which is why we're doing all these trials.
Excellent. Thank you, Dr. Caudell. I think the next question follows very closely to that, and maybe between Dr. Ahmed and Dr. Caudell, any of you can take that. How is AI currently being used in radiation oncology research?
So the major current application of AI in radiation oncology is for normal tissue contouring. There are a multitude of companies that have provided or sell deep learning models that contour normal organs for us. And just so you understand, at least in head and neck, it takes me probably 60 to 120 minutes to fully contour all the different normal organs in a head and neck case. And deep learning models do this in 30 to 60 seconds. The question is the quality. And so what we've shown, at least in our internal deep learning models, is that quality is relatively good. What we need going forward in the future, and what we're currently doing research on, is whether we can use AI and deep learning models to plan radiation. So currently that process takes 4 to 6 hours, at least for a head and neck case, which is a huge improvement over the 1 to 2 days it took even 5 years ago. But if we can get that down to 1 minute, 2 minutes with deep learning, then it opens up a huge potential for further personalization of an individual patient. If it only takes us, a grand total of a few minutes to recontour and replan a patient, then they potentially can get a new plan every day. And that's a huge thing potentially for reductions in side effects and not missing tumor.
If I could add on quickly to that too, we have an integrated mathematical oncology department here on the research side that is heavily involved in AI technology. And if you think of the thousands of patients that have been treated at Moffitt with radiation therapy, they're really leveraging that data in an unidentified way to come up with strategies to predict dosing, timing, etc., that can be customized for patients.
Excellent. And these are ever-changing and growing field that we are very confident that Moffitt is taking the lead on. The next question is, does prostate volume drive decision whether to use external beam radiotherapy or brachytherapy? And the question is absolutely. The way to look at it is actually we put everything together, not just the prostate volume, but also other aspects of the treatment plan and also the patient side effects. But if you think about it in a more of a simplified manner, you can compare the surface area of a golf ball to the surface area of a baseball, right? So the amount of surrounding surface, if you had to wrap a paper around each of them, was going to have a bigger area around around the golf ball have the smallest area, and the baseball have the larger area. And so prostate size will also impact side effects, right? Because there'll be normal tissues around that organ will dictate how much of the normal tissues will be exposed to unwanted radiotherapy. And so sometimes what happens with the bigger glands and the swelling that is associated with the bigger glands is that you may end up having to adjust which technique you use. And this is why at Moffitt Cancer Center, we have all these advanced technologies so that we can pick the right one for the patient. It's not one size fits all, even when it comes to our technology, right? So not only are we going down to the biological underpinnings of our treatments, but the anatomy factors into what kind of technology we use. So not every patient will need brachytherapy, not every patient will need proton therapy, and not every patient will need external beam. So it allows us to really tailor all these treatments to the patient, what the patient needs. So great question there. The other question that was asked was since these studies, a lot of the trials that both Dr. Ahmed and Dr. Caudell presented are patient-centric. How are the algorithm and the metrics generated to dictate the performance for these patients in these studies? So if you are dosing based on GARD or dosing based on these things, what's the algorithm you're using to determine who will benefit and how to benefit when you are making those adjustments? So this is quite of a question that I think a lot of us are working through. So Dr. Ahmed, do you want to take that?
Sure. Yeah. So I think that really depends on the cancer site specifically. So when we're looking at the radiation sensitivity index and GARD, it's a really personalized approach where, one size does not fit all. So for example, for our triple negative breast cancer trial, we're looking at real world clinical trial data for local recurrence risk for triple negative breast cancer patients. And we powered that to ultimately have a 20 to 30% improvement in local control in that study. And and that's true of other RSI and GARD trials that we're running as well too. It really depends on the specific tumor type, and we're looking at improving clinical trial performance utilizing our specific metrics in radiation oncology.
Yeah, so one of the advantages or inherent advantages of radiation oncology is we collect enormous amounts of data, which is, as Dr. Lynch mentioned, one of the reasons that we partner with the mathematical oncology department, the machine learning department. And so, for example, in head and neck, we have enormous amounts of data on organs at risk that receive radiation. And we can generate models that are prognostic for medium-term, long-term toxicity. And then by putting the new data going forward prospectively into those models, we can say, all right, well, you're going to have a 5% lower risk of swallowing trouble 6 months after, and you'll have 3% less risk of swallowing troubles 12 months after. And therefore, this extra effort that we take doing replans or putting you on proton therapy makes a lot of sense. So individualizing patient decisions based on the models that we generate from all the people that went before.
Excellent. Well, and this is an ongoing field of a lot of effort among all our investigators. I want to transition to another question that goes to Dr. Lynch as well. So what makes CAR T appealing as an immunotherapy for prostate cancer?
So it's a great question, and thank you for it. CAR T therapy is really revolutionizing how we're treating patients. And again, as I mentioned, while there's a lot of treatments available for prostate cancer patients that work really well, I think Moffitt's really leading the way in terms of clinical trials, especially when it comes to cellular therapies. For prostate cancer in particular, for men that have become resistant to therapies that worked well once, really we're looking for new options to treat those patients. And so again, molecularly, we can look at what prostate cancer cells are expressing, and there's an antigen or a little protein that they make that's called prostate stem cell antigen. And we've developed CAR T to recognize that antigen. And so the CAR T cell can lock onto the cancer cell and eradicate it. And so what makes it appealing then is that it's cancer cell specific. So this prostate stem cell antigen is only expressed by the prostate cancer cells in the bone microenvironment, for example. And so the off-target effect, so, when we give a small molecule inhibitor, sometimes we're hitting other cells as well, and that's what gives rise to toxicity sometimes. But these CAR T cells are very specific, and they can recognize and kill the cancer cells without having a lot of off-target complications usually. And I will also put a plug in for Moffitt Research too, because we're one of 5 FDA-approved facilities that can generate these CAR T or cellular products to infuse back into our patients. So again, really leading the way here in terms of cellular therapies and clinical trials emanating from them, and asking how radiation obviously can help improve the efficacy of those trials as well.
Absolutely. This question will go to Dr. Ahmed, specifically asking, I think, reference to one of your studies ongoing. Are there current studies or radiation treatments available for clear cell metastatic renal cell that is in the brain or in the head or in the lungs as well?
Yeah, so we do have some studies that are ongoing looking at patients who have renal cell carcinoma that's metastatic. So one of them I mentioned, it was the Limitless study that's going to be opening from Dr. Oliver and from Dr. Redler, but then specifically looking at whether we can enhance the immune stimulatory effect from radiation therapy by delivering low doses of radiation therapy for patients who have multiple sites of disease greater than 10. So that is a very novel trial that's going to be opening within our department, and we're excited about seeing the potential there.
Excellent. Now, the next 2 questions are related. And the first one, I would say I would first pose it to Dr. Caudell first, and then the second one will follow right after that. It says, if a person has throat cancer, stage 0, and has 30 rounds of radiation and is cured, and then 30 years later, cancer appears in the mouth, stage 1, can a person receive radiation again?
Yes.
And he said the reason being, someone had told the person that you can get radiation only one time.
We do it all the time. We do it all the time.
Right. And to add a little bit to that, which you follow up with the next question, is that how does the new proton therapy deal with kidney movement? So part of the concepts of re-radiation that Dr. Caudell has spoken about, I think also Dr. Ahmed had mentioned earlier, with our novel studies in re-radiation head and neck cancer by our radiation oncologist, Dr. Michelle Echevarria, looking at being able to do this safely and effectively and actually extending the disease control rates, is because of a lot of what we've discussed so far: the precision, the imaging quality, the ability to really respect normal tissues and be able to re-radiate. So some of these things may not have been possible maybe 40 years ago, 30 years ago, but that's not the case today. At Moffitt Cancer Center, we're able to very, very safely re-radiate patients that need it. And because we have expertise and also the knowledge and depth of knowledge to know what can be safely done to extend disease control. But that also leads us to newer technologies that was coming up when the person that asked the question about the new proton therapy dealing with kidney movement. So that's a phenomenal question, because, as you know, organs in the body are in motion constantly. And so part of what we do within our department is that we are able to pay attention to organs that move more than others. So some organs move a lot more. The bowels, the other structures, the lungs, the things in the mediastinum, they're constantly shifting around, or, a lung tumor when the patient is breathing. Well, there's a lot of these things that we factor in. And so we, as I mentioned earlier, we take a a specific technology that can deal with that. So we have an MR-Linac that's able to actually look at the motion management. We actually can have patients hold their breath, and we have techniques that will monitor the breathing patterns in a very comfortable way to deliver that precisely. We have technologies that we call triggered imaging, where you have specific, we call them fiducials, so we have specific markers within the tumor that will tell us when there's motion. And if that's detected, the equipment will take a pause on delivering radiotherapy and then be able to proceed and deliver radiotherapy within that zone of accurate limits that have been put on it. The beauty of a proton center is that you can have the proton beam also deliver the radiotherapy in a precise manner. And even though the motion management may not be as qualitative as an MRI, we would also use that in critical areas. The kidneys are not constantly moving as much as the lungs, right? So you're able to actually do something we call the retroperitoneal regions that are behind the stomach, behind the peritoneum. They are really adhering to a lot of fibrous tissue and the muscles of the back. So they're able to hold them in place. And whether it's a lesion on top of the kidney or within the kidney, proton therapy can be very, very effective. So yes, your question is yes, we're able to effectively deal with that and are able to deliver precise treatments to organs like that. And so these are all upcoming in 2026. So stay tuned to how we do this for our patients coming to Moffitt. And the other question that came in closely after the proton therapy unit was, how do we decide which radiation therapy to use for each patient? And I kind of dovetailed into it a little bit, but I want to open it to anyone who wants to add more to what I just mentioned to make some clarifications there. Kamran, Jimmy.
Yeah, so I think it really depends on the patient. We have a lot of different modalities that are available and we can employ when needed, but it really depends on the tumor site that we're treating, the adjacent organs that are at risk as well too. And so at Moffitt, we're able to utilize a lot of the technologies that Dr. Yamoah described and to pick the right modality for patients, but it's really patient-centric and dependent on where we're treating patients.
Excellent, great. And one other question following here, and I think this is a very important question, which says, I was not aware of the potential permanent damage to lymphatic systems due to radiotherapy. What is being done to avoid the damage, or what can be done post-treatment to reverse this damage? Now, a very important question, because there is the understanding of treatments that are specific to organs that are close to lymphatic channels or vessels, and how that can be complicated several-fold with other companion treatments. And one classic example is when you have breast surgery and axillary dissection, where they take out the lymph nodes in the armpit area, right? And then because of the pathology report, you got to go back and irradiate that area. So you end up disrupting the lymphatic channels based on the surgery, and by itself, you could have gotten away with it. But when you introduce radiotherapy on top of that, you can actually worsen that lymphatic drainage and cause arm swelling and things like that. We see the same thing in the pelvic area. If you have surgery and you have 70 lymph nodes taken out of the pelvis, and then you go back in there and irradiate that region, now you can amplify the problem. So it's almost like a double hit. It's never radiotherapy alone being the initiator. It's often a disruption by other curative procedures. And when you come in the back end, you can amplify that side effect. So it's important to understand the mechanisms here. We don't have supporting evidence that radiotherapy alone is enough to damage blood vessels or things like that. But when you have surgical manipulations going on, yes, that can become a significant risk. So I just wanted to make sure that that's clarified in the context of side effects from radiotherapy. It's always sometimes can be not just additive, synergistic when you have certain other manipulations done. But as a specialty, we have multidisciplinary consultations. So most of our very challenging cases go through a multidisciplinary team of surgeons and medical oncologists and case reviews that looks at the risk and benefits. And if the benefit proceeding outweighs the risk, then it's a calculated risk. And that's how we end up proceeding with therapies here at Moffitt. Any other comments on that from my experts before we move on to?
I just want to clarify, at least in relation to the question, that permanent damage is probably a strong statement. As in radiation, as we have solved so many problems, at least in head and neck, for example, it used to be 80-90% of patients got tubes in their stomach, and now we're down to less than 20%. We used to have trouble with folks, their voice, their parotids, their saliva, their taste, et cetera, et cetera. As radiation has improved over the past 20, 25 years, these problems have become less and less. And now we see other problems that were masked because patients didn't survive or patients had bigger problems to complain about. I don't want to say complain, but bigger problems to address. Um, and so we kind of see this now. For example, in head and neck, we treat many lymph node areas prophylactically, and there are many active trials reducing the amount of dose to lymph node levels. We see in the most recent trial comparing protons versus photons that lymphopenia was less with protons, probably because there was less bone marrow spill of radiation, there was less radiation to blood vessels. And so we've become very aware of this issue, particularly in the era of immunotherapy, where you need to have an intact immune system to get the best response. And so, for example, in Dr. Oliver's trial that is coming out, one of the things that we do on this trial is we look at lymph node compartments, the bone marrow, the spleen, the major blood vessels, to correlate the dose that was received with ultimate lymphopenia as well as with ultimate efficacy. So we're thinking about these things. We're trying to solve these issues and new planning methods, new organs at risk, and new technologies like proton therapy may help us address this even in a more careful manner.
Thank you, Dr. Caudell. This is excellent response. Well said. And I want to answer a question real quick and ask the next one, and probably answer that one as well, and then we can go to another question on clinical trial. So, a question was: is there a doctor at Moffitt who specializes in kidney cancer and proton therapy? And the answer is yes. Our entire genitourinary group, myself, Dr. Johnstone, Dr. Grass, Dr. Anupam Rishi, Dr. Dan Fernandez. We have five of us that specialize in GU radiation oncology. And also we have our surgeons, we have a bunch of our surgeons that focus on that, Dr. Spies, Dr. Brandon Manley, and Cole, that would actually focus on the surgical side of kidney cancer management. And whether it's something that requires a surgical management or if it comes to the combined immunotherapy end of things, we also have our medical oncologists that do that. Whatever the issues, I have a multidisciplinary team of GU radiation oncologists, medical oncologists, and surgeons that can actually address that. So what that is, I think Moffitt is a place to be to answer that question. And going on to another question somewhat related to what Dr. Caudell mentioned is radiation therapy recommended while on Keytruda infusions? And I think that question dovetails to exactly what disease sites it is, what the side effects are, and whether it's something that requires an intact immune system. What area are we concerned that maybe by irradiating what regimen will be to modulate the immune system that will impact the use of Keytruda or other agents. So it's not a straightforward answer without knowing the context. But to that question, say a lot of what Dr. Caudell said about combination therapies of the immune system, about lymphatics, all applies to that specific question. So please work with your physician and your physician teams to really address that question more effectively. And so then the other one, yes, go ahead.
Yeah, I do want to emphasize that, all of these tools that we have at Moffitt, MRI Linac, Ethos, TrueBeams, brachytherapy, and soon proton therapy. These are all tools that are not independent from site-specific expertise. That's what we have here at Moffitt is site-specific expertise. The GU group has 5 people, head and neck has 4 people, the breast team has 4 people that all they think about is that particular type of cancer, that particular body site, and can leverage the different technologies that we have to provide the best treatment for an individual patient. So proton expertise, well, it's a tool, and we're all going to be experts at it, probably me most of all, with a positive phase 3 trial in head and neck cancer.
Absolutely. Again, Dr. Caudell, as always, well said and well answered. Thank you so much for that response. Really spot on. The other question was how much research is needed before a clinical trial can be developed? And there are no better 2 people on this call than Dr. Caudell and Dr. Ahmed, who spent decades working on this topic. So go for it.
Yeah, so a lot of clinical trials really start where Dr. Yamoah and Dr. Lynch are located in the lab, and it can really take years, decades of research in the lab before something can move into clinical testing on patients. So a lot of research is certainly needed before it can actually ultimately be tested in patients, and then from there, there's different phases of clinical trials as well too. So phase one, just testing initial safety, phase two, initial efficacy, and then phase three, really changing them the standard of care. So we have all different phases of clinical trials going on with our department, and a lot of collaborative relationships that exist with researchers in the lab like Dr. Lynch.
So to give a concrete example, we've talked about RSI and GARD a lot today, and Dr. Torres Roca started that research in the lab about 20 years ago. To generate the signature, to create the mathematical model for GARD, to obtain the prospective data from previously published clinical trials and enormous retrospective databases, to generate the data to say, hey, this is a good idea, let's run clinical trials. That has been a 20-year process.
Sometimes it's a little quicker as well. Another concrete example is the work with Daniel Abadadaga, where we were looking at these gamma delta T cells as a CAR T product. And I would say we published the paper probably within about 3 years. And in May of 2023, it came out. And in April the following year, we started a phase one clinical trial across in the clinic. And I think that's why I love doing research here, is because everything that we do is 100% cancer focused. We're a cancer center. And a lot of us came here because of the ability to translate our research into clinical trials that really happen on the clinical side as well.
Absolutely. And so
certainly
yes,
things go faster sometimes, particularly with machine learning models and mathematical oncology models. We ran a trial in head and neck cancer where the modeling to completion of the trial was within 5 years.
And so for all of you interested in helping out, think of it like there are different phases of clinical trial development. And sometimes the rate limiting step is the funding to move it from one step to the next. So you can have a brilliant life-saving option stuck in one of those 20-year phases. So it's not like these things are not all going on at different phases of development. So being able to stay engaged in environments like this, or working with our major gift officers to say, if there's any disease side of interest or any innovation that you're interested in supporting, having interaction with our team to say, here's something that is ready for prime time. Would you want to move it off the shelf and move it into the clinic and move into patients and let us move cures forward? Those are the kinds of things that we are always ready to share with you for anyone who is interested in the support. So I think we any other comments before we wrap things up? I think we're almost close to time here. We have 2 minutes or so more.
We answered all the questions.
Looks like we've answered all the questions here, and we do want to thank all of you. It's great for sticking with this and being here, and we want to make sure we can continue the dialogue beyond this webinar. And I want to wish everyone a happy holidays, and we'll see you in the new year. Thank you.
Thank you.
Thank you.